Good afternoon, and thank you everyone for attending today's webinar, 2017 Telemedicine Update, presented by Michael Schaff and Grace Mack of Willens, Goldman, and Spitzer. Please be aware that there will be a question and answer portion today at the end of the webinar. To avoid frequent interruptions during the webinar, please type your questions in the question box located on the right of your screen. They will be answered in the order received during the question and answer portion. Additionally, an electronic version of this presentation will be emailed to all participants following completion of today's webinar, and a recorded version will be available on the website for members only. Again, NJMGMA would like to thank you for attending, and I'll now turn things over to Michael.
Hi, good afternoon. I appreciate the fact that you decided to spend your Valentine's Day time lunch with Grace and myself. As you can see, we have little hearts on here. If you need to send something by the internet, I will accept roses and other nice chocolates. In any event, what we're going to talk about today is a 2017 telemedicine update. By the way, my name is Michael Schaff. I'm the chair of the Healthcare and Corporate Departments of Willens, Goldman, and Spitzer. And Grace?
I'm Grace Mack. I am also a shareholder with the Health and Corporate Department at Willens, Goldman, and Spitzer.
So today what we're going to talk about is, it's really an update. We did a webinar about last year on this, and we're going to talk about the key definitions of telemedicine, the types of telemedicine, licensure issues, current issues with New York telemedicine laws, current issues with New Jersey telemedicine laws. We're going to talk a little about reimbursement for telemedicine. I know that's important for everyone. Some issues associated with remote prescribing, whether or not telemedicine is right for your practice, what the implementation process is, and what the future is and what goes on beyond 2017 and emerging trends. One thing that we've done is, to make this very educational, we decide always to show our favorite cartoon, the Jetsons, with respect to telemedicine and how they, back in the 60s was a little bit ahead of their time.
School. I don't feel good, Mom. I think I'm coming down with Venus virus.
Venus virus, hey? Last week you said it was Martian mumps. Anything to miss the space calculus test.
I tell you, I'm sick. Oh, this is it. It's growing black. Quick. Where's a pencil? I gotta make up my will.
All right, hold on. Just hold on. I'll call the doctor. Calling Dr. Racy. Dr. Ken Racy.
Yes, Mrs. Jetson. Somebody got a pain in the tummy tum-tum?
It's Elroy, doctor. I think it's the Venus virus this time.
Venus virus? Oh, that can be catching. All righty, Elroy. This is your dedicated physician speaking. Stick out your tongue. Oh, my.
Well, what do you see, doctor?
2 dozen gumdrops, a pastrami sandwich, half a pizza.
Elroy! For breakfast?
Well, you see, I thought it was my last day on Earth.
Yes. Well, it pains me to tell you, but there's only one known cure.
What's that?
A full day at school. You're fine.
Oh, phooey.
Elroy! Thank you, Dr. Racy. Sorry to call you needlessly.
Think nothing of it, madam. It's my duty as the nation's #1 dedicated physician. Which reminds me, one house call, the usual fee. No hurry on the bill. Tomorrow morning will be fine. Happy medicine.
Well, Elroy, you just spent your father's raise.
Gee, I'm sorry, Mom.
So, for those of you who have not seen this before, it's kind of enjoyable, but there's a lot in here. And how are the Jetsons and telemedicine related, or what's involved with respect to it? A number of questions come up. Number one is the doctor licensed in the state where Elroy is located? I don't know the answer to that. Do you? Was there some type of informal consent associated with that? Was this a counter secure? Today we have HIPAA. What do you deal with? How do you deal with it? And was the reimbursement appropriate? Is $100 for a minute visit okay? Was it in or out of network? Many questions come up. So with that, I'm going to turn it over to Grace and say, you know, what, Grace, really is telemedicine?
Well, telemedicine has, the definition varies depending upon which source you're looking at, but there is a common theme throughout all of them. So I'm going to give you a couple of the examples so you get a little bit of the feel for it. The example that Medicare uses as to what telemedicine is two-way, real-time, interactive communication between the patient and distant site physician or practitioner, but not communication via telephone, email, or fax. So the Jetsons would be telemedicine under that definition because the patient is at a different site than Dr. Racy. Another definition of telemedicine is the New York definition, which New York has a telemedicine law in effect currently as of January of 2015. And their definition is delivery of healthcare through real two-way electronic audio-visual communication, including the application of secure video conferencing or store and forward technology to provide or support the delivery of healthcare. We'll get into a little more what store and forward means in some of these other definitions. But New York, in addition to defining telemedicine, it also defines telehealth, which is broader than telemedicine, and it defines telehealth as a delivery of healthcare services by means of information and communication technologies, consisting of telephones, remote patient monitoring devices, or other electronic means. So sometimes there's another definition of telehealth, sometimes it's just telemedicine, and sometimes they're not even consistent with each other. So it is all over the place. And since we're here in New Jersey does not have a telemedicine bill as of yet, but there is one proposed, which we'll go into more detail later on. But the proposed Senate bill, which is 291, defines telemedicine as the delivery of a healthcare service using electronic communications, information technology, or other electronic or technological means to bridge the gap between a healthcare provider who is located at one site and a patient who is located at a different remote site, the Jetsons example. It also provides it's either with or without the assistance of an intervening healthcare provider, which is important because some states require an intervening healthcare provider. In other words, there would have to be a healthcare provider where Elroy and Mrs. Jetsons were, whether it be at a practitioner's office or at the location where the patient is. There could be another physician or a nurse practitioner or some other intervening healthcare provider. But the New Jersey proposed law does not require that, whether that is going to be in the, the law that ends up being passed, but the current proposed bill does not have that requirement. And it goes on to say, which typically involves the provision of healthcare services through the application of secure two-way video conferencing or store and forward technology, and is designed to replicate the traditional in-person encounter and interaction between healthcare practitioner and patient by allowing for interactive, real-time visual and auditory communications and the electronic transmission of imaging, diagnostics, and medical records. That's a lot of words, so hopefully when we're done with this presentation we'll have more of an understanding of what they're really trying to address.
Okay, so you define what telemedicine is. What is not telemedicine, Grace?
Well, telemedicine is not audio-only telephone conversation. So you talk to the physician, a patient talks to the physician on the telephone. That's not telemedicine, that's just regular medicine if it's providing medical care. Emails, not telemedicine. Instant messaging, not telemedicine. Phone text, not telemedicine, or facsimiles are not telemedicine. And these are based on definitions provided through Medicare and through the proposed bill. Just a general idea. Again, it's not, you can't get one answer to any of these questions, unfortunately.
Okay, so we've dealt with that. Why don't you go over some of the key telemedicine terms, Grace?
Sure. Well, an important term, if you're going to be dealing in the telemedicine world, is distant site, which is the distant site or the hub, and that's the location where the distant site provider, or sometimes called remote provider, is located. And that's in the Jetsons example, that would be Dr. Racely's office or wherever he's located. I'm not sure if he was actually in an office, but where Dr. Racely is located, that would be the distant site or the hub. I
think he was in a bar at the time.
And then we have the originating site or the spoke, and that would be the location of the patient at the time the service is provided. So that would be the Jetsons' home. So that would be the originating site or the spoke. And there could be more than one spoke off the hub, so Dr. Racely could be treating other patients at the same time. Not at the same time, but from the same distant site. The remote provider or the distant site provider is the provider who provides this service via telemedicine who is not at the same location as the patient, Dr. Racy. The telepresenter or the provider extender would be the provider or support personnel at the originating site who assists the remote provider. And that would be the example that I gave you before, that if there was another provider or practitioner located at the Jetson's home or where the patient is.
Okay, so why don't you tell us about some other types of telemedicine, Grace?
Well, one of the types that is frequently used is store and forward. And store and forward telemedicine is the transfer of data from one site to another site through the use of a camera or similar device that records an image that is sent via telecommunication to another site for consultation. Some examples would be digital images of a skin rash or clinical data sent concerning glucose levels or EKG measurements or a pre-recorded video of the patient. Another type is remote patient monitoring. And remote patient monitoring is the use of telemedicine technology to collect data from patients from one location to be interpreted and used to offer a diagnosis or provide medical care from another location. And it could include services provided in real time. Some examples would be at-home diabetes, cardiac, or pulmonary monitoring. Another example would be intraoperative monitoring done during neurosurgery. The physician who's interpreting the data is not located at the same site as the patient, but it is data that's being transferred, not the patient interaction. The other type of telemedicine, which is really the one that people think about, I think, most of the time when they hear of telemedicine, is interactive video conferencing. And that's an interactive exam via audio-video conferencing. The provider interacts with patients via real-time video conferencing to diagnose and treat. Examples, the Jetsons example is an example, but other examples would be primary care treatment to patients in rural areas who are unable to access care, or access to specialists who may not otherwise be available. Another example, which is really telehealth and not telemedicine, is mobile health, which people think of as telemedicine as well. And that's the use of cell phones, tablets, apps, or wearable devices to manage and track health conditions, fitness, or lifestyle. So examples of mHealth or mobile health would be a Fitbit, or patient portals for scheduling, or medication apps. These are not telemedicine, but they fall within the broader definition of telehealth.
Okay, so you're dealing with telemedicine issues. What kind of licensure issues are required or raised when you're dealing with providing telemedicine?
Well, generally, the practice of medicine occurs where the patient is located, unless an exception applies. So it's where the patient is located at the time the telemedicine technologies are used. So the Jetsons example, to go back to that again, would be where the Jetsons were located. So Dr. Racy should be licensed not just where he is, but where Elroy's located. And the process to obtain licensure to provide telemedicine varies from state to state, and it's dictated by each state's Medical Practice Act. So you have to review the license requirements of the state where any patient is located that you're going to be treating. New Jersey licensure requirements, not dealing specifically with telemedicine because there is no law yet on that, but they require that any person commencing the practice of medicine or surgery in New Jersey must be licensed to do so. So there are a couple of minor exceptions, one being a lawfully qualified physician or surgeon of another state taking charge temporarily on written permission of the board of the practice of a lawfully qualified physician during his absence from the state. So that's very limited. And then there's another exception, a physician or surgeon of another state of the United States duly authorized to practice in that state if the practitioner does not open an office or place for the practice of his profession in this state. So this is a provision that some people have interpreting as allowing physicians outside of the state to treat patients in New Jersey or New Jersey patients, but it has to be if they don't have an office in New Jersey. And whether practicing through telemedicine would be considered having an office in New Jersey, this is subject to interpretation, but the application of this exception in the past has really limited to physicians who are not regularly engaging in New Jersey. So most likely this would not allow physicians from out of state to regularly engage in telemedicine. But the proposed law, which we'll get into more detail, that NJS 291, it does allow for if it's passed, it will allow for a reciprocal license, which is a streamlined provision that will allow out-of-state practitioners to provide telemedicine to patients in New Jersey pursuant to this reciprocal medical practice license. And as I mentioned before, New York does have a telemedicine law, and it's important for practitioners in New Jersey, since we do border on New York, and a lot of our physicians from New Jersey do practice in both states. So, and another reason it's good to study is because it gives us guidance on a law that's already in operation. So the New York law also limits the practice of medicine to people licensed in the state. But it does have an exception that says any physician who is licensed in a bordering state and who resides near a border of this state, provided such practice is limited in this state to the vicinity of such border, and provided such physician does not maintain an office or place to meet patients or receive calls within this state. And it also has an exception for a physician who is licensed in another state or country who is meeting a physician licensed in this state for the purpose of a consultation, provided such practice is limited to such consultation. So these are also limited exceptions.
So what does it mean? It means that if you are a doctor who practices in New Jersey and have an office in New Jersey, but you live in New York, you can practice out of your house? Technically, maybe.
Well, if you're doing it, if you're regularly engaging it,
right,
it could be problematic.
Okay.
And the New York Department of Health has a statement on telemedicine, and it does clarify that it is the location of the patient that defines where the care has been delivered and the jurisdiction of the applicable regulations. Physicians and physician's assistants who practice or hold out to practice or engage in any physician-patient relationship in New York must be licensed and currently registered in New York. So the practice of medicine, even through telemedicine in New York State, by someone who is not authorized to practice in New York State, may constitute the illegal practice of a profession. But the licensure and cross-border practice of medicine is really moving quickly, and the laws are adjusting to it. There's a federation of state medical boards, and they have adopted an interstate medical compact, which really addresses issues that are coming to all the medical boards across the country. So in their recent survey, they did find that telemedicine was the most important regulatory topic for state medical boards in 2016. So many state legislatures and medical boards are considering the adoption of telemedicine laws and also model legislation, which is proposed by this Federation of State Medical Boards. And they have come up with this compact for interstate licensure. And many states have already enacted legislation that they will participate in the compact, although the compact is not yet up and running. Under this compact, the participating state medical boards would retain their licensing and disciplinary authority, but would agree to share information and processes essential to the licensing and regulation of physicians who practice across state borders. Participation in the compact would be voluntary for both states and physicians. As of January of 2017, 18 states have signed this interstate compact. I have the states listed up there, and it has been introduced in Michigan.
But it's not in New Jersey yet.
Well, New York and New Jersey have not signed the compact. However, NJS 291, that proposed law, which again we don't know if it's going to be passed, but that does provide that the New Jersey Board of Medical Examiners shall evaluate the telemedicine licensure compact currently being promoted by the model boards, and determine if state action and legislation is necessary to allow the states to participate in the compact. So they're to study it and then report back in 180 days if it's something that New Jersey would consider beneficial.
So keep in mind it's on the horizon.
If the law gets passed.
Right.
Mm-hmm.
With practices, I think it's a little bit more important, not only whether or not and how they can practice telemedicine, but is telemedicine reimbursed, and if so, how?
Well, again, it's not an easy answer, and it's not black and white. It really depends payer by payer, state by state, contract by contract. So Currently, Medicare covers telemedicine, but only in limited circumstances. There are geographic restrictions, so the originating site must be in a county outside of a metropolitan statistical area, a designated rural health area, in a designated rural health area, or a rural census tract. So it's only in those areas where you can really get reimbursement for Medicare, and again, this is where the patient is located. There are also originating site restrictions, eligible distance site restrictions, and eligible telecommunications technology is required. So you really have to look at what you're doing and where you're doing it for Medicare. And Medicare, they've been expanding on this, and there have been updates to their reimbursement. So in 2014, they expanded coverage to include payment for telehealth services originating in certain additional rural areas. They also, in 2015, the Medicare fee schedule added several telehealth services to be covered by Medicare if you qualify for the other restrictions as well. And also in 2016, they added some new telemedicine codes. So if you practice Medicare, if you accept Medicare, you can look to see if you fit within these restrictions, but you have to be careful because it is very restricted, but it is expanding, so really keep an eye on that. And then state law and commercial payers. New York has a telemedicine parity law. In January of 2015, they became the 22nd state to enact telemedicine commercial reimbursement. For the most part, it requires health insurance to pay for covered services delivered through telehealth and telemedicine as long as the services and the providers are otherwise covered under the patient's contract. So as to commercial payers, it requires them to cover services via telemedicine if provided by hospitals, home care, hospice, licensed physicians, physician's assistants, pathologists, or other types of providers. And it prohibits the exclusion from coverage for a service provided via telehealth if that service is otherwise covered in person. So if it's something that you could get reimbursed for an in-person visit, they're required to cover it through telemedicine. The requirement is for commercial payers and Medicaid in New York. There are some distinctions between the two in New York. The commercial insurance law requires a broader definition of telehealth than the Medicaid law. The commercial insurance law also does not define a narrow band of eligible telehealth providers, nor does it differentiate between real-time, store and forward, or remote patient monitoring. The commercial insurance law contains no originating site restriction, thereby significantly increasing opportunities for patient care access to via telehealth in New York. But it does clarify that while an insurer is prohibited from excluding coverage for a service that is otherwise covered under a policy delivered via telehealth, an insurer may not exclude coverage for a service rendered by a healthcare provider if the provider is not if it is not otherwise covered under the insurance policy. So it doesn't broaden things that are reimbursed. The important thing to note about the New York telemedicine parity law is that it provides for parity for reimbursement, but it doesn't provide for payment parity, which is a very important distinction. So although the intent of it was to ensure patients may receive covered services in person or via telehealth, the statute does not require payment parity. So the insurance company is not required to pay the same amount for that service. They just have to cover it. So this has led to a lot of issues in New York and a lot of problems. So in May of 2016, there was another bill introduced in New York, the Payment Parity Bill, which is the Payment Parity Bill. And this does seek to amend the New York Insurance Code governing private health insurers to require them to reimburse on the same basis and the same rate as if it were not delivered via telehealth. So we'll have to keep an eye on that one. Now, New Jersey, as I mentioned before, there is a bill, S-291, which is proposed, but in the past there have been other telemedicine bills in New Jersey that have not moved forward to enactment. And we are one of the few states, I think there are only 2 states that don't have telemedicine laws. So I think it is coming. I don't know if this one is going to be the one, but in the past there was a bill A-1464, which in March of 2016 the Assembly recommended not to enact. But this new bill, on November 3rd, 2016, the New Jersey Senate Budget and Appropriations Committee voted favorably on it, so it is moving forward through the process. So we're going to spend a little time, but not too much time, since it might not be passed, just giving you the highlights of what it would do. So it addresses the use of telemedicine in New Jersey, including how it must be practiced and how providers will be compensated. It provides for a reciprocal license, so if passed, it would allow out-of-state practitioners to provide telemedicine to patients in New Jersey pursuant to a reciprocal medical practice license. It does have payment parity, unlike New York, so it has a payment parity provision that would require insurance companies compensate providers at the same rate, whether an appointment is conducted remotely or face-to-face. But this is the controversial provision of the bill, as you can expect, and it's getting a lot of pushback from the payers. So we'll have to really wait and see how that turns out. Also, the bill, the New Jersey bill, it's not just doctors. It provides that telemedicine may be provided by physician's assistants, nurse practitioners, psychologists, psychiatrists, psychoanalysts, clinical social workers,
lawyers.
Not lawyers, or any other healthcare professional acting within the scope of license. Another interesting example of telemedicine and how you can look at two sides of it. I mean, we know that it has pros and it has cons, and it really depends on the situation. So the recent death of Prince is a good example of showing the two sides of telemedicine. The Minnesota statute, which is where Prince was located, requires physicians to be licensed in the state and registered to practice telemedicine. They have a registration process where out-of-state physicians can be registered to practice telemedicine. So when Prince died, there were two articles in the same week. One of them said, could telemedicine or concierge physician have saved Prince's life? It said, today's age is where physicians and healthcare providers can take blood pressure and listen to heart sounds remotely, or obtain a history from a patient via teleconferencing. Would a concierge physician who Prince could access via telemedicine save his life? So that was one article. The same week, there was another article. Questions arise about California doctors' response to Prince. Dr. Howard Cornfield, a California licensed physician, practiced medicine in Minnesota to treat Prince, even though he was not licensed to practice medicine in Minnesota, nor possess a telemedicine registration. That was what the article said, and it ended. Was this a contributing factor to his death? So one article said telemedicine might have contributed to his death, and another article said it could have saved his life. So it really is a two-sided issue, whether telemedicine is a good or bad thing, depending upon how you look at it and the circumstance.
Okay, so we discussed how telemedicine would work. You know, maybe you can explain what remote prescribing is and what concerns they raise.
Sure. Remote prescribing is not e-prescribing, which to me sounded the same. So I just clarified this because I myself was confused about it. So e-prescribing is sending electronic prescriptions to pharmacies. So we're not talking about e-prescribing, we're talking about remote prescribing, which is the prescribing remotely by a physician who's not in the same place as the patient. So remote prescribing is regulated by the Department of Health of each state, the Board of Pharmacy, and also the Federal Drug Enforcement Agency. So generally, prescriptions must be issued in connection with a valid prescriber-patient relationship and an appropriate examination. What does that mean? Does that include telemedicine? Well, New York, currently there's no explicit guidance in New York concerning remote prescribing. Again, we're focusing on New York and New Jersey because the two states are nearby. So in New York, a pharmacist may fill a valid prescription so long as it is ordered based on a bona fide physician-patient relationship. A statement on telemedicine from the New York board said, if a patient receives professional advice or treatment, even gratuitously, there is a prima facie evidence that a physician-patient relationship exists. Health information sites access for general information only without personal interaction through electronic media does not constitute a professional physician relationship. So there's two extremes. What is it? Is telemedicine or remote enough for a physician-patient relationship? New York, we don't really have guidance. In New Jersey, there is no current guidance as to telemedicine and remote prescribing. The proposed law does state that a physician may prescribe, dispense, or administer a medication or a drug, including a controlled or non-controlled substance, to a patient in this state, provided the physician has first engaged in a face-to-face examination of the patient. And then it adds, either directly through traditional in-person means or methods, or remotely through the use of telemedicine in a manner that conforms to the accepted standard of care and rules of practice. And the prescription is done in compliance with law. So this law, if passed, will allow remote prescribing if there's a face-to-face by telemedicine. So it couldn't be stored forward, it couldn't be a phone, it would have to be one of those video conferencing following all the other rules of a patient examination.
Just like the Jetsons.
Probably not enough in the Jetsons, but if this is passed, there is that possibility. There are additional restrictions if it's a controlled dangerous substance prescription. There is a federal law on remote prescribing, the Ryan Haidt Online Pharmacy Consumer Protection Act of 2008, and this narrowly permits remote prescription of controlled substances for patients without an in-person evaluation, so long as the patient is in a hospital or is treated by, or a clinic with a DEA registration, or treated by a DEA practitioner in the usual course of professional practice in accordance with state law. So this act on Online Pharmacy Consumer Protection Act, it was from 2008, so it's really not totally up to date with telemedicine, and the interpretation and the extent of it is not clear, but there is a proposed amendment to this act, so we'll see that also will probably help clarify some of these questions. There also was a recent case in Texas which gives us a little bit of flavor on these issues with remote prescribing and out-of-state licenses. So Teladoc, we all know Teladoc, they were doing business in Texas, and the Texas board voted to not allow physicians to prescribe without having a physician-patient relationship, which they felt required a face-to-face encounter. And they passed this vote that these type of teledoc relationships would not qualify. So Teladoc sued, and the rule was stayed. So the rule is still stayed, and Teladoc filed an antitrust lawsuit against the Texas Medical Board, alleging that the board behaved like a cartel by passing rules to limit competition. So and the FTC actually sided with Teladoc, saying that the medical board was misinterpreting case law and trying to really restrict things within the state.
So Grace, you've given us a little history. You've gone over New Jersey and New York law and what's proposed in New Jersey. But let's think a little bit forward. What are the future trends in telemedicine? Where do you think it's going?
Well, there's a lot going on in telemedicine on both the state and the federal level. Recently, in December of 2016, the Cures Act, the 21st Century Cures Act, was passed. I know it did a lot of things that are not covered in this seminar, but one of the things that it did do is it contained a directive from Congress for further study into the use of technology for the delivery of healthcare services. This Cures Act directive provides that CMS should expand the list of eligible originating sites that we talked to before, those many limits on Medicare. It also, the criteria that we talked about, the limits, the type of care, the location, the classification, they really had this directive to study it and try to expand on those. And under this directive, it gave CMS until December 14th of 2017 to deliver a report to Congress containing this information. So it will be interesting to see what comes out of that. And then a second bill that was passed, the ECHO bill, which I guess it's the second bill, so ECHO might be the name for it. But this was passed into law the following day, and this detailed additional research to be conducted by HHS into the use of technology to connect urban and rural healthcare providers. The ECHO Act seeks to build on Project ECHO, which was initiated in the University of New Mexico. This project created a hub-and-spoke platform that we talked about before, the hub being the physician, the distant site physician, and the spoke being the other sites. So this would connect urban healthcare specialists with rural healthcare providers to enable the delivery of healthcare in rural areas. No direct doctor-to-patient care is provided through Project ECHO. Instead, these participate through teleconferences and grand rounds so that they may collaborate and share medical knowledge. So in this case, there is that intervening doctor that we set in the middle. So here's an example. You know, the urban specialist would be in one location, and the rural doctors would be in their spokes with the patient. Under the ECHO Act, Congress directs HHS to study and then report back to Congress its findings on the role that technology can serve to promote the collaboration between rural and urban centers. And being in the New Jersey area, as you know, we are urban centers, might be something that affects practice here. By December of 2018, HHS must deliver a report which describes the impact of these models on healthcare provider retention. In addition, it also calls for HHS to work with stakeholders to analyze technology-enabled collaborative learning, capacity building models. So that's another interesting to see what comes out of these in the future. And also, it is estimated that by 2020, telemedicine will be a $34 billion industry. So it's just increasing exponentially. Another interesting article was Here Come the Drones, and this was talked about an innovation for telemedicine where it was developed by a dean in Mississippi, and he wanted physicians to be able to deal better with crises when they're not near the patient, and his personal experiences was with the after effects of the tornado that leveled the town where he was from. So the way this would work is it would be guided by a GPS, and the drone would drop a modular medical kit with diagnostic and treatment equipment for the patient's situation. It would be like a heart attack kit or a trauma kit or a high fever kit. And in fact, the FDA has already approved an EKG recording device that attaches to a smartphone with a thermal camera to take the patient's temperature. This kit would then allow for live video feed connecting the patient with the healthcare professionals who will guide them on how to use the kit. I know it's in the future, maybe not as far in the future as the Jetsons, but it just shows some interesting innovations that could be used with telemedicine. So as we've seen, there's state activity. The Federation of State Medical Boards found that telemedicine is the most important regulatory topic for medical boards. And it is also likely that from our personal point of view, there's going to be state activity in New Jersey on the telemedicine bill. Likely in 2017, we can't guarantee, but might not be the law that we discussed today, but probably some form of law. And then federal activity. The Federal Century Cures Act, the ECHO Act are requiring studies to further encourage the adoption and reimbursement of telemedicine.
Okay, so just to give you a little prelude, at the annual meeting, which will be in June for the NGMA down in Atlantic City, we're going to do a telemedicine presentation on if you're really considering to do telemedicine in your practice, you know, what you should consider before you add telemedicine in your practice. And Grace is going to give you a little prelude to it.
Well, if you're considering adding telemedicine to your practice, you really have to review the pros and cons that are specific to your practice, because telemedicine is not one size fits all. I mean, you really have to review and consider the medical duty of care and practice standards for the delivery of care by telemedicine for your practice. I mean, is it something that it would work for? Is it something that it creates risks? I mean, will the use of telemedicine increase access, or will it compromise quality of care? Or will it do both? I mean, this is really a decision that the practice has to make as far as will it work for your practice. Another really important thing to do is to prepare, if you're considering it and you decide to go forward based on your practice, is to prepare a detailed business plan on the cost and implementation and the expected revenue. You know, how much is it going to cost me to put this in? How far do I want to go? Do I want to do simple technology? Do I want to lease it? And what is my expected revenue from this? Is it enough to justify it? And then if you do go forward, there's an implementation process that has to be followed. And the first thing, you would have to really define the scope of services that you're going to be providing and come up with the best model for providing them. Prepare a plan, negotiate the legal documents, and then implement the program. And then you have to develop a plan to monitor outcomes of your program. And then there's a lot of other regulatory and practical considerations that you have to really consider. The first is informed consent. You have to have the proper informed consent from the patient. You have to check your liability insurance coverage. You have to make sure that the policy specifically covers these services when they're provided by telemedicine. You have to have information privacy and data security. Any technology that you're using has to really comply with HIPAA. As we know, that's really a big issue these days. You have to be careful with potential technology-related issues. What if it breaks down? What if the computer or the camera breaks down? Do you have a reputable company? Is there backup? You have to talk about data ownership, retention, destruction with any of the vendors that you're working with. You also have to be concerned with the corporate practice of medicine and fee-splitting prohibitions, depending upon how the billing is done for the service you're providing. If you're doing it with other types of relationships. You have to have documentation of visits. The standard of care is that things are done the same way via telemedicine that they're done in a regular in-person exam.
That's provided you're doing it right now.
Right. And then you need compliance with fraud and abuse and other laws. I mean, those are always in play no matter what you're doing when there's a relationships with other parties.
Okay, so we left you about 15 minutes to see if anyone had any questions, or if you wanted to, you can run out to the CVS and buy me a box of chocolate for Valentine's Day. So I'm not sure if there's a list of questions or not.
We do have one question. Can patients self-pay if their doctor offers telemedicine? If my office offered it as a service, can I charge them as self-pay?
Well, I think the first question is you have to look at the managed care contract associated with it, because there may be some prohibitions with respect to whether or not whatever is being provided is a covered service or not. But generally, it should not be an issue, but you really need to make sure you're in compliance with the applicable contracts that are involved. Okay, any other questions?
Does anybody else have any other questions? Does the fact that S-291 hasn't passed yet in New Jersey prohibit providing these services in the state currently, or does it just mean a lack of government? Are payers paying today for these codes?
Okay, I guess
I missed the ending of the...
Yeah, you asked two questions. Maybe you can break them up because we didn't catch that.
Okay. Does the fact that S-291 hasn't passed yet in New Jersey prohibit providing these services in the state currently?
Okay, period, question mark.
Okay, okay. It doesn't prohibit it, it just means we don't have any guidance on what the parameters are.
Correct, and what you may be doing, if you're from outside the state, you may be deemed violating your licensure if you don't have a license within the state.
Yeah, I think
you also have to take in consideration you're probably not going to be reimbursed for it.
Unless you have to really look at the payers' policies. There are
Right.
some programs that do pay for it.
Right. What's the second question there, Alex?
It was, are the payers paying today for these codes?
And then it depends.
It depends.
That's the perfect lawyer answer. It depends. We actually have an entire class, second year in law school, and it's titled "It Depends," and I'm really good at answering that one. Any other questions?
If you're licensed in Maryland, if you're a licensed MD in New Jersey, what if the patient contacts the MD from Pennsylvania? Can the MD provide telemedicine?
But we'd have to look at the Pennsylvania licensing laws on that. They might allow for, a consultation or an existing patient. I mean, that is governed by the Pennsylvania licensing laws, which, we're not licensed in Pennsylvania, so I don't know that answer.
Right, but you generally would need to look at the licensure issues in two states. The state in which the doctor is located when they're performing this and the state in which the patient is located. Okay?
Next time we'll include Pennsylvania too as a bordering state, but right
yeah, we'll
now.
get everybody dizzy. Any other questions?
It just says you mentioned PA has the Interstate Medical Licensure Compact.
Oh, they've adopted.
Yeah, they've adopted it, but it's not in place yet. All the states they've agreed that when it's in place, they'll follow it, but it's not in effect yet. The compact, even though these states agreed to abide by it when it's enacted, but it's not enacted yet.
Any other questions?
Does the New Jersey proposed law and New York laws require an in-person relationship to have been established to perform a telehealth visit?
The question is, does New York require an in-person patient relationship before they can do it through a telemedicine or telehealth?
Yeah.
Not generally. I mean, it could be for controlled dangerous substances.
So the answer is generally no, unless it's for.
Well, we'll have to clarify, but yeah, that's my understanding.
Does anybody else have any questions?
So we have about 10 more minutes, so you do all have time to run to the CVS and get Alex, Grace, and myself a nice box of chocolates.
Thank you everyone for attending, and the presentation will be emailed out this afternoon and also available on the website.
Thank you, and if anyone has any future questions, our email address is on this slide, and feel free to email us.
And thank you, and happy Valentine's Day.
Have a good day, everyone.